Hello everyone, my name is Nora, and today we'll be talking about death, dying, and hospice care, understanding the end-of-life care. What is death and dying? Dying well is ultimately about living fully and consciously in whatever way one chooses until the moment of death. When an older adult enters hospice care, the constraints of the illness has already influenced the patient's decision about their care. The patient's goal is to achieve a quality of life within their desired environment. The resilience model gives the patients at the end of life the capacity to continue living a meaningful life and may also be a springboard to future psychological growth. The resilience model is similar to the strengths-based perspective. It acknowledges its limits in the face of the challenge. However, it promotes the capacity of people to adapt these limits at the end of life. What is hospice? Hospice has been funded since 1983 and it's a service that provides to the terminally ill and their families. Hospice care provides essential services including medical care, pain management, as well as emotional and spiritual support for patients at the end of care. It is funded by Medicare, Medicaid, and private donations. Anyone is eligible if they need additional support or at the end of life care. Some myths and facts about hospice. Myth: hospice is a place. Fact: hospice can take place wherever the older adult calls home. This could be a skilled nursing facility, in their home, with family, or in an assisted living. Myth: hospice is only for cancer patients. Fact: hospice provides care to older adults in a variety of terminal illnesses. Some examples include cancer, chronic lung disease, and cardiovascular disease. Myth: hospice is only for the sick family member. Fact: the focus for hospice care is not only medical care, but emotional, social, and spiritual needs for the entire family. Hospice provides caregivers and family members counseling and bereavement services up to 13 months after death. What is bereavement and grief? Bereavement is a common experience in older adults. Majority of older adults recover after the loss of a loved one. A portion continues to grieve for an extended period of time and develops symptoms known as complicated grief or prolonged grief disorder. Complicated grief is associated with a number of negative health outcomes, such as hypertension, sleep impairment, and risk for suicide. Complicated grief is underdiagnosed, and it most commonly seen in older adults who are mourning the loss of a spouse or a longtime partner. Complicated grief most occurs in older adults who have watched family members suffer very long or very short, if they had a cognitive impairment, if the death occurred unexpectedly, or if the patient died in a hospital setting. During the bereavement period, it is important to have natural and social supports because it decreases the risk for social isolation and maintains the quality of life. If social or natural supports are not available, then professional care should be explored. Other factors that play a role in bereavement are age, gender, and social economic status. This depends on the person and the family member they lost. Other contributing factors are if it was a death of a child, spouse, or if they experienced depression prior to the death, are all factors based on how well they will process grief. When working with family members, some roles of the social workers are social workers who care for terminally ill patients and provide emotional support for their partners should pay attention to possible pre-loss depression. This is depression that they were experienced prior to their loved one, prior to the loved one was deceased. The social worker should conduct evidence-based assessments for the partner to refer them to either bereavement or mental health specialists. The social worker should educate who is eligible for hospice, provide end-of-life support for the patient and the family, be open-minded and avoid judgment, be mindful of religious and spiritual beliefs, create a safe space for the family, discuss confidentiality, and provide additional support and resources. Micro-level social work. When a patient or family is referred to hospice, meet with the individual first, depending on the capacity of the client and a family, to discuss the benefits of hospice. Provide an open door policy and open communication. They may not need therapy sessions at this time, but may need it in the future. Also provide additional resources and referrals. Macro. Provide individual therapy to the patient or partner. Identify the level of care and conduct evidence based on assessment. Explore family history and develop treatment for the future. On a federal level, discuss the importance and advocate for the need for Medicare. Advocate on a federal, state, and local level for quality of end-of-life care. Meso. Provide information trainings for hospice care and the services hospice provides. These trainings should be done at hospitals, nursing homes, skilled facilities, community centers, senior centers, and adult day centers. This will increase referrals and understanding about hospice care. I included this in the meso level because in one of the articles they discussed that people just don't know about hospice, and that doctors, even though they work in hospitals or have their own physicians, they just don't know about the service, and then therefore people are not referred. I included churches because on a spiritual level, some people may not know that hospice provides rabbis, priests, reverends, so that will educate older adults and families as well. And this will increase the referrals and the understanding about hospice care. Develop training programs for doctors' offices and hospitals. Develop trainings in regards to who pays for hospice. A lot of people think that they have to pay out of pocket, which they do not. Insurance does cover it. Target rural and urban areas. And target older adults with all types of insurance. One of the articles I read said that mainly older adults in urban areas were receiving hospice compared to older adults in rural areas. Reach out to different race, religion, and cultures. Identify that each family grieves in a different way. Code of ethics. Service. Provide a non-judgmental therapy to the family in need. Dignity and worth of the person. Treat each person in a caring and respectful fashion. Be mindful of religion, cultural beliefs, individual differences, and ethnic differences. Important of human relationships. Social workers understand the sensitivity of the relationship. Create a safe and comfortable means of communication. Allow the patient and family to provide as little or as much information as they feel comfortable with. Integrity. Upon first meeting, discuss confidentiality with the family. Okay. All right. So this was my presentation. I hope you enjoyed it. One of the questions I had was, do you think men or women would be more open to bereavement services, men or women caregivers? Thank you.